Welcome officially to the second official Geospatial Consortium and Community of Practice event. Um, and it's officially our first panel and roundtable. And so our theme today is conceptualizing opioid geographies. So a little bit of an agenda for what we'll be talking about today. I'll introduce myself, share a little bit about what we'll be talking about, a little bit more about what the GCCP is and what our goals are. Also introduce our lead moderator who will be taking over the panel in just a minute. Then we'll be going into our panel and discussion on our thematic topic today. And around 4 o'clock, or 4 o'clock Central Standard Time. So on the hour, we'll shift to our roundtable. So at that point, feel free to stay, but we also understand some folks only have an hour for these meetings, but that will be kind of a natural transition time. We'll have that roundtable for about half an hour, and then we'll be shifting to our closing. So folks will be ready to get out of here within an hour and a half. So what is a geospatial consortium and community? What we're referring to as the GCCP. We are a new collaboration of researchers, practitioners, and community members that meet to learn how geospatial models can help us understand the opioid epidemic. We like to discuss current topics regarding opioid research and advocacy, kind of within that wider spatial, placial perspective. And we also like to share resources, projects, and opportunities that can kind of encourage more collaboration and support across the entire network. So for more information, feel free to go to this website here, gccp.healthyregions.org. Mark or Rachel from our team will drop that into the chat so you can get there directly if you haven't already been. So in the chat at this point, we invite you to share your name, affiliation, and interests that led you to joining us today. Feel free to use in light of the next generation, feel free to use all the emojis that you need to. One of our older traditions is to use 3 emojis to introduce yourself, but you can also be old school and use plain old text and language. That would be totally fine. As you're doing that, this session will be recorded and shared. So our goal is to be our goal is to provide information, discussion, interesting perspectives in a way that can benefit as many people as possible. So as a result of that, we'll be kind of taking the recording of what we're doing today and sharing that. So with that being said, if you'd like to have your video enabled, please be presentable. If you're eating, kindly disable your video and audio. We will have staff on hand to kindly or unkindly disable your video and audio for you if you're not following these rules. So just kind of some friendly rule of house type of things. And then today, if you have questions, we really, really encourage you to use the Q&A feature. If you're not able to see that as one of the primary icons on your Zoom, if you click that option, there's a circle with 3 dots in it called More. So click on that, and in the More setting, you'll find a Q&A there. And so we ask you to put your question there so that we can kind of systematically incorporate those with the moderator questions later to answer those. Of course, be kind and respectful in the chat. We've in this group value collaboration over competition. Be mindful how your tone may get lost over text. And we also want to be helpful to all of you. So session aides will be monitoring the session for compliance as well as assistance. So feel free to hash or at or message Mark or Rachel. And then Mark and Rachel, if you guys wanted to also introduce yourselves in the chat, that way folks will know who you are and who they can reach out to if they're having any challenges. So today we'll have the session moderated by the Geospatial Core leads. So this is officially initially starting off as a project by JCoin and the NIH HEAL Network. You'll learn a little bit more about that later on. And we do have more information on that on the website as well. So I'm Dr. Kolek. I lead up the Healthy Regions and Policies Lab. Depending on what group I'm in, I'll introduce myself as either a health geographer, spatial epidemiologist, or spatial data scientist. Dr. Budrum, would you like to introduce
Yes.
yourself?
Hi, I'm Basmati Budram. I'm a professor in the Division of Community Health Sciences at the University of Illinois School of Public Health. I'm primarily an empirical researcher. I focus on the intersection of substance use, infectious disease, and social networks and other structural factors driving adverse outcomes in the population. Thank you.
And our panelists today will first be joined. And so these three panelists have done the very brave task of taking on our first kind of robust discussion on the topic. So huge thanks for your bravery and interest to bring this all to task. So first, we'll be joined by Noah Kravchuk from New York University, then by Paul Jodry from University of Pittsburgh, and then finally Sylvia McKelvey at the University of Oxford. And so I'll share a little bit more details about each as we introduce things in the next few minutes. But with that, I think we're just about on time. Let's kick off the panel. So our panelists were invited to essentially share their views on opioid geographies in quotes broadly. Each panelist will have about 10 minutes to share their view on our panel theme. And panelists will share, in this case, how they view space, geography, and place when discussing, conceptualizing, and/or modeling the opioid epidemic. And how they do that is really up to them. So this could include a range of views, including more of a focus on approaches to modeling and quantitative measurement, alternatively, more theoretical, conceptual frameworks and epistemological perspectives, as well as applied work examples, professional experiences, how these topics might impact policy. So I think you'll find that there's a lot of different perspectives that the group here has to share. And you'll find that we had also recommended readings that were recommended by the panelists. And me being very biased on this topic, I also added one as well. So I apologize in advance. But if you check out that website that we shared earlier, gccp.healthyregions.org, you'll be able to find the complete list of recommended readings, and we'll also highlight that throughout, as well as copies that you can use for now. So with that, we're going to shift over to Dr. Kravchuk, who's an assistant professor in the Department of Public Health or Population Health at the NYU Grossman School of Medicine and associate director of the Center for Opioid Epidemiology and Policy. Her research focuses on studying ways to address barriers to evidence-based treatment for opioid use disorder at the individual, program, and policy levels. Over the past few years, Dr. Kravchuk has been working to develop agent-based models in collaboration with New York State Office of Services and Supports to help simulate the impact of alternative methadone treatment policies, as well as access points on overdose outcomes in New York. So with that, I'll stop sharing and kick things over to Dr. Kravchuk.
Great. Thank you so much. I will just share my slides. You all see them okay? Great. Well, thank you so much for having me. It's really exciting to be part of this panel. I'm pretty new to working in kind of the geography space and thinking about this really intentionally. So just thrilled to be here and learn from you all and share a little bit of my own thinking kind of as an epidemiologist and health services researcher working to think about issues around the opioid epidemic for a little while now. Just to give you really brief background of kind of where I'm coming from, I'm part of the NYU Center for Opioid Epidemiology and Policy. We're a group of people dedicated to doing a lot of different multidisciplinary research around substance use. So this is the amazing team that I work with, including many who have worked on
Wait, really
some of the
quickly,
research.
Dr. Kravchuk, it looks like it reverted to I think there we go.
Right, there you
Okay,
go.
perfect.
Thank you. Yeah, so just wanted to shout out to our team and many of the people involved in the research I'll be talking about today. And then just to talk about my own approach, my research really aims to think about multi-level influences on access to health services and particularly addiction health services. And so I'm, even though I was trained mostly as an epidemiologist, I really think about the importance of combining health policy services research, use a lot of mixed and different methods, and really thinking about kind of implementation, science, dissemination, and collaboration across disciplines in order to really try and address the different levels that are needed to, I think, expand access to addiction health services. So just another kind of reason that I'm excited to be working amongst you all and that are in different disciplines to think through this issue. I think it's reverting again. Sorry, my try not. Okay. Just let me know if it pops back. So a lot of my research career has really been focused on trying to address this kind of what I think many of us know as this MOUD access dilemma, or medications for opioid use disorder access dilemma, where we know that we have very effective treatments for opioid use disorder, including these medications listed here, methadone, buprenorphine, and extended release naltrexone. And particularly the first two, methadone and buprenorphine, have a really long history of use and studies that have shown that they're extremely effective in improving many different outcomes, but particularly reducing overdose risk. So this is just one example from a study we conducted a few years back in Maryland, where you see the blue line. This is a survival curve among people who are receiving treatment. And the people in blue were receiving treatments not involving these medications, and the people in red were receiving treatments involving medications. And you see that those receiving methadone or buprenorphine have much greater rates of survival. And we see this time and time again. Probably very familiar to those in this room. However, we have this persistent gap in access to these medications despite their effectiveness. This is also another study we conducted to try and estimate kind of what the really size of that gap might be using administrative data. And we see that the gap between the top line, which is the estimated opioid use disorder prevalence, and the number of people actually receiving these medications is very large, despite having kind of improved utilization over the last few years. So in terms of kind of conceptualizing this gap, I really think of it as a two-part gap. On one hand, this treatment gap relates to lack of treatment availability. So where people can receive, if they even have availability of these medications. And the second is really around treatment utilization. So even when these medications are available, many people still don't utilize them. And I think that this is really where a lot of our work needs to do in terms of reducing that treatment gap. So to kind of think of the role of geography specifically in this question, if we think about kind of lack of availability plus lack of utilization leading to lack of access, and I'm trying to be a little bit more intentional. I think we use the word access a lot, but really what does that come to? A lot of our studies, particularly in epidemiology around kind of the rhetoric or research related to the geography of these medications, has really focused on availability. Where are these programs? So this is an example. This is just a map we created of counties in the United States that have opioid treatment programs, which are the only licensed facilities where you can receive methadone. And you see that many counties, most counties, don't have an opioid treatment program or an OTP. And I'll use kind of this example of methadone throughout the rest of my talk as well. So clearly we have an availability issue, and we have a lot of research, including Paul's research that's been really fundamental in really our understanding of kind of how far do people live, how difficult is it to access many of these for many people living in different geographic areas, particularly rural areas. And this is just an example from a very recent study in Connecticut, where they looked at the relationship between travel time, either driving or via public transportation, based on where opioid treatment programs are located in the state, and kind of looking at average travel time in different areas of the state, depending on different sociodemographic characteristics. So a lot of research on kind of how far do people live or how long does it take them to get medications. But a lot of this work has really kind of looked at this on average, not necessarily based on where people actually live, which has been is obviously a limitation, which is because it's difficult to get that information, right? Where do people with opioid use disorder or needs live? That denominator is always a big kind of methodological challenge in our studies. But especially when it comes to methadone and buprenorphine and many other treatments, it's not just about lack of availability, as we talked about, it's really about lack of utilization as well. And we know that particularly around methadone, there are many, many reasons for why people choose not to utilize methadone from opioid treatment programs, including financial burdens, a lot of requirements for attendance and expectations of abstinence and other high threshold requirements, and culture that's really not consistent with what people are seeking, and many things that people don't want to do, like mandated counseling or drug testing, and many other things. So thinking about utilization is really, really important, particularly when thinking about this methadone access problem. And I think what's really exciting now, and kind of to tie this back to some of our conversations later around policy and engaging with community groups, there's been a lot of movement in recent years to try and reimagine methadone and our treatment system, both in terms of expanding availability and utilization of methadone. This is just some examples of many of the documents and proposed bills and recommendations that have come out around really envisioning methadone differently, with more access and potentially access through different points of care beyond opioid treatment programs. So in my last couple of minutes, I just want to kind of dive into a really brief example of one study that we're doing, and how we can use modern tools in epidemiology, specifically simulation modeling, to try and better understand how availability and utilization of methadone particularly might look like under alternative methadone policy scenarios. And what's really exciting about simulation modeling is that we're able to simulate something that doesn't exist. And in our case, we're not able to just study a policy that doesn't exist or has never been implemented in the US. So simulation modeling is a really useful tool here. And what we did, in brief, our study is called the Simulating the Impact of Methadone Prescribing and Pharmacy Dispensing on Overdose in New York State. And we essentially are simulating, comparing three different policy scenarios. The first is the status quo, which you can see here in green. That's where only methadone is available through opioid treatment programs. The second is actually what was proposed by a particular bill around expanding methadone to addiction medicine certified providers. And the third is really a model in which even general practitioners or primary care prescribers could prescribe methadone. And that's based on many recommendations that groups, including our collaborations with the National Coalition to Liberate Methadone, have really emphasized. And just to really briefly show what even availability would look like under these alternative scenarios, we graphed the current state of OTP availability in New York State. And you can just see, even just with these brief images, how much access to both initiation points and dispensing points changes under the different scenarios. So in scenario B, you have initiation points from addiction specialist prescribers, while in scenario C, you also have those primary care prescribers in blue. So what about methadone utilization? And this is very preliminary. We're also trying to think, how can we simulate where people actually live in comparison to where they receive their treatment? And this is just an example in our model. Particularly, we're actually simulating agents based on a synthetic population, using information, geographic information on the distribution of opioid use disorder outcomes, including overdose and treatment, to actually try and model where people live and how that relates to their outcomes. And we found, and just a really preliminary finding, where we're trying to understand how does actually the distance to treatment impact retention and care. And we see that actually the relationship is not very straightforward. There's some relationship in terms of longer distances impacting how much people are able to be retained in care, but the relationship is certainly not straightforward. A lot more to look at here. And I think really what will be interesting, and just to give a preview of kind of what will be coming in this project, since I know I'm running out of time, um, what we really want to know is what is the impact of having shorter distances to this pharmacy or office-based model? How does that impact initiation, not just retention and care among people already accessing treatment? And how does the setting itself uh, impact retention initiation in terms of whether people would want to utilize these treatment options? And we can simulate this based on many different assumptions using these models. So with that, I'll just thank my collaborators and the grant support for this project, and look forward to discussing further.
Thank you. So feel free to share your, hands clapping emojis and that sort of thing as needed. Um, so we're going to actually shift right next to the next panelist so they can give their perspective. And again, we'll have kind of the whole Q&A discussion following. But right now, if you have questions as they come up during the talks, please add them to the Q&A function. So in your Zoom toolbar at the bottom, there's a little circle with 3 dots in it that says more. Click on that, and through that, you'll be able to access Q&A. Type in a question, submit it, and we'll be able to share that. So with that, let's move on to Paul Chaudhry. He is a certified as an internist and addiction medicine specialist. And Dr. Chaudhry's research focuses on identifying barriers to accessing person-centered substance use disorder treatment across urban and rural communities, and developing, evaluating, and scaling interventions to address those barriers. His current areas of focus include improving the measurement of community access to medications for opioid use disorder, implementing shared decision-making for methadone treatment, and evaluating the effectiveness and implementation of office-based methadone in the U.S. His research prioritizes rural populations and building new community partnerships among people with lived and living experiences of methadone treatment. So with that, we'll shift over to Dr. Chaudhry. And also at this time, a friendly reminder to please feel free to introduce yourself in the chat. Tell us where you're from, why you're here. That kind of helps build community as well.
Great. Thank you, Dr. Kolak, and really excited to join this panel, and grateful for the invitation and opportunity. Let me share my screen here and get to presenter mode, hopefully. Are you guys seeing the right screen? Great. All
We're
right.
seeing the screen with the sidebar.
Okay, just one second. Let me.
Yeah, PowerPoint has been a little funky today.
No worries. I think I know what happened. Try this. Did we get to the right?
Yep, that's it.
Great, perfect. All right. So I'm going to talk about aspiring for participatory opioid environments. And I'm definitely approaching this from a theoretical standpoint, and I'm really kind of focusing on what I see as a key challenge in the field as we're theorizing about opioid risk environments. And in terms of disclosures, no conflicts of interest. I do think it's important for me to just acknowledge that I serve on the board of directors for the National Coalition to Liberate Methadone, and I'm funded. Sources are from the NIH. I also think it's useful. I want to talk about kind of the position and experience that I come from in terms of shaping how I think about these things. I'm a clinician and a health services researcher. I grew up in Mansfield, Ohio, on my parents' farm, and kind of came of age with what we now think of as the overdose epidemic in the United States. My family itself has a history of severe mental illness and substance use disorders in my family, and I came of age with this. Deeply impacted my community, and of course that sense of place for me growing up in rural Ohio, and seeing how place shaped both my family's experience and other people around me had a big effect on how I think about these things and how I approach it. And I think that's an important starting point to acknowledge as we think about this. And so I only have 10 minutes, so I'm going to kind of jump in, and here's kind of the key points that I want to try to make and begin. And I'll admit, I'm theorizing here, and this is not this. You won't see a lot of solutions presented here, but because I think this is partly a challenge for the field. But part of what I'm going to argue here is that mistrust of science and medical institutions limit the impact of interventions for people who use opioids. And there can be a tension between developing technically sophisticated opioid environments in the geography space and connecting and building trust with local communities. And the kind of key point that I'm hoping to advance is that conceptualization and measurement of opioid environments should prioritize participation in the agency of people who use opioids in their local and their local communities to maximize trust and impact. So let's get into, what I mean by this and why I think this is so important. So kind of picking right up with Dr. Krawczyk, we feel very similarly on these things, but the NIH knows this. This is not new news. There's a problem. We have a challenge with bringing scientific, medically well substantiated treatments, interventions, innovations into the real world, implementing them and ensuring that communities and individuals who could benefit them receive them. And, kind of the classic example within opioid use disorder space is medications for opioid use disorder. But I would also, remind us that this goes beyond people who use drugs. You could look at vaccines, you could look at other innovations. We live in a time when there is a growing distrust of institutions, medical, scientific, otherwise, and this is impacting our ability to improve the health of the communities we aim to serve. And so, both from kind of my own direct experience of where I grew up and kind of my firsthand experience of seeing some of these things, we previously kind of developed this idea some. And one of the things that I think is important to conceptualize when we think about, a kind of an underappreciated part of this is how important it is to recognize the historical antecedents of mistrust. Sometimes when we're thinking about the lack of adoption of healthcare interventions and why people may not choose to utilize them, et cetera, we may focus on the more immediate causes, the more proximate causes. And those things are important. But sometimes what that ends up obscuring is the historical violations of trust that communities have previously experienced that may shape their perceptions of the institutions and the places that are attempting to provide or promote the interventions we're hoping to bring to communities. And so to address, one of the key things that we argue here is that meaningful participation in the governance of science and medicine is needed to reduce and prevent mistrust. But let me give you some examples of kind of what I mean here to try to be a little more concrete. There's some really classic examples. I mean, and in this context too, I think the way in which place is connected to these becomes very clear. But one example, many of you may be familiar with this, is the Tuskegee syphilis study that was conducted in the American South among rural Black Americans. And this is where scientific institutions, research institutions, and the government infected individuals with syphilis without their consent and without their knowledge. And this is, of course, one very striking example of a violation of trust and a violation of ethical principles carried out by institutions charged with trying to promote the health of these communities. But I also think, we can look at coming back to opioid use disorder, and we'll also use the example of methadone. You can have communities who, and this is an example both historically there's been a lot of suspicion and resistance to methadone treatment and the locating of methadone clinics within Black communities in the United States. And methadone treatment works. Methadone treatment could benefit individuals in these communities. But the important thing to understand about the resistance to locating methadone clinics in these communities is often how these clinics are deployed, the site they're chosen to be placed, often is done in a way that the local community, and in this case, Black communities, have very little political agency, very little opportunity to participate in the decision making that goes into where the clinic's located, how will it be run, who will it serve. And this creates a gap where mistrust, suspicion, and conspiracies can fill in. And so these examples, where you have a lack of participation, creates space for what on the outside might see like, well, of course, like people are dying of overdose. We need methadone. That gap in participation leaves space for suspicion and resistance to come in. And so this is a big problem that we face. I want to flip it around though, because it isn't all negative. I also want to say that the flip side, there's evidence of positive results. And so if we flip it around, where we see where communities have come together, marginalized communities, and we're focusing on people who use drugs here. So I have examples of the Junkie Bond movement in the Netherlands, and then ACT UP movement in NYC. And one is directly related to people who use drugs, the other indirectly. But the flip side of this is when people come together, organize, and seek to expand their voice, expand their agency, and to participate in the governance of health services, you can see the flip side of things, where the delivery of services changes, the delivery of services expands, the delivery of services accommodates more people. And so, again, though, kind of emphasizing this point that participation matters. And so, to kind of, I think, though, the point that I want to make too is that participation is particularly important in the setting of drug use and addictive behaviors. And so broadly, participation is necessary to fulfill the bioethical obligation of respect for autonomy. And there's lots of writing on this, but just loss of agency is also a general part of the experience of poor health. When someone is sick, one of the things that it's experienced partly as a loss of control of your life to some degree. And I think this is even further driven in the case there's a loss of agency is central to the experience of addictive behaviors. And this can come in a different ways depending on how you theorize about addiction. But one that I favor, and I suspect this audience does too, given our collective interest in how place shapes health, is that ecological theories of addiction suggest that increasing a sense of citizenship and the freedom to identify with healthy, non-addictive behaviors may be the key to improving our health. So how an individual situated in a place experiences a sense of citizenship and freedom to identify with healthy behaviors is part of the theoretical framing here. Is that's a key factor in the ability to people to choose to utilize services that might benefit them. And I'll say too, these points, we have this, there's a commentary where it's under review at International Journal of Drug Policy. So we hope that we can have this formalized and share some of these points soon. So the other thing, coming kind of back, so we could agree theoretically that participation is important, but there's some powerful barriers that make participation difficult. And one is that there's a perception gap among marginalized people who use drugs, and then sometimes among well-meaning institutions, scientists, medical providers, professional organizations. There's not always understood the places where we're not meeting, where participation is not occurring. We might think we're doing a good job, but it's not It's not nearly as good as we think it is. There's inertia in these institutions where we've always done it this way. We don't need to include people at the table for this decision. How could we change? Um, Social vulnerability itself, of course, can make it hard for people to participate. We might all agree that we need more participation among people who use drugs, but the social circumstances they're embedded in makes it hard for them to show up for that meeting, makes it hard for them to respond to their email. Um, and then in the addiction space, this comes from both. There's a general belief in that there's an irrational user. The notion that people who use drugs and people with who are seen as having a use disorder or addiction, that they're not capable of pursuing their own interests. And this is both could be seen by a reductionist brain disease model of addiction, but also if people are tightly hewed to a moral framework where addiction is seen as a flaw in someone's character. Um, and then, so there's stigma and imbalances in social standing and power may foreclose people from participating, institutional policies. And then the last one I want to highlight in particular is what we've been calling survivorship bias in participation. And what I mean by that is there could be places where, and this is a place where I think we really need to talk about more and do a better job of. There might be places, scientific institutions, medical, where we try to expand participation. We invite clients, patients, community members to the table. We have to acknowledge, though, that the people who are able to come to those meetings, able to show up to the advisory board, feel comfortable speaking, often may be the people who their social circumstances enable them, allow them to show up. The most vulnerable, the most, take the example of a methadone clinic. The people who can't follow the rules, who get kicked out of the program, will also be the ones who are least likely to join the advisory board, least likely to submit a satisfaction survey. And we really have to grapple with this part about how do we expand participation among the people who might find it the most difficult.
And
So,
Dr. Jandri, I have to, because we're about 2 minutes over, so I have to switch
sorry.
over to our next panelist.
Got it. Okay, sorry, I went over.
Fantastic, though. All right, so I will very briefly introduce our final speaker, but I know that there's going to be a good discussion here, so I'm really looking forward to that. So our final speaker is Sylvia McKelvey, who's a PhD candidate in geography and the environment at the University of Oxford, where her current project examines harm reduction activism and advocacy in Greater Los Angeles, drawing on long-term ethnographic research conducted alongside low-barrier syringe service programs. She investigates how care is practiced for and by people who use drugs across marginalized suburban spaces such as sidewalks, parks, temporary accommodation, drop-in centers, and encampments. Her work brings together health geography, critical drug studies, and feminist science and technology studies to examine the relationships, emotions, and forms of advocacy that shape communities affected by the toxic drug supply crisis. She has previously conducted comparative research in San Francisco and Vancouver, Canada, on a grassroots naloxone distribution work and has held community-based participatory research positions in the area of sexual violence and trauma-informed care. So with that, please go for it, Dr. McKelvey, or soon to be Dr. McKelvey. And I should note, I am aware that we are running a little behind, so we'll plan to have about a 10-minute discussion at the very end of this. Okay.
Thank you, Dr. Kolak. Let me just make sure you got my slides here. All good? Great.
Oh, I think we just lost the slides.
Oh, did you?
Okay.
Is it still lost?
Can other folks see it, or is it just me? Yeah, I think we just see the community panel.
Okay, let me try again. Do it this way. Is that working?
Perfect.
Okay,
Yep, go for
great.
it.
Okay, thank you, everyone. It's a pleasure to be here with you today. So I'm going to explore how we might think about opioid geographies through the lens of care. Drawing on health geography and feminist and science technology studies, my doctoral work looks broadly at community-based harm reduction in Greater LA. Now, by harm reduction, I mean a set of practical strategies and political commitments that aim to reduce the health, social, and legal harms associated with illicit drug use, including some of the interventions listed here today and some that have already been mentioned and talked through. As a feminist drug ethnographer, I focus particularly on low barrier and peer-led harm reduction organizations and mutual aid networks, many of which serve unhoused or precariously housed people who use drugs. I come to this idea of feminist drug ethnography through my own early work and activism starting in 2011 in my hometown of Vancouver, Canada. And so now my research has emerged to more focus on Greater Los Angeles and is based on 14 months of fieldwork and 55 interviews where I examine how harm reductionists and people who use drugs create and sustain care amid overlapping crises, including an unregulated drug supply. Now, before turning to some of my findings, which I'll talk through today, I want to situate us within this idea of a slow emergency. This has been helpful for me to understand, even in my own 15 years of working in this field and being an activist in this field, how we kind of contextualize these overlapping crises. The toxic drug supply crisis, as I use typically in my terminology, also could be opioid, also could be overdose, is often told as a story of waves, from the expansion of prescription opioids in the 1990s to the rise of heroin-related deaths around 2010, and the proliferation of fentanyl and other synthetics into the 2010s, and more recently, intensified drug-related risks during the COVID-19 pandemic and increased poly drug use. County-level analyses further conclude there is no longer a single national crisis. Now, drawing on Lauren Berlant's work on slow death, or the attritional wearing down of particular populations, Rhodes and Lancaster argue that what we call the opioid or toxic drug supply crisis is less a series of discrete waves than a 40-year slow emergency. In their account, increased risks like overdose are not isolated outbreaks, but an endemic condition produced through decades of structural violence, criminalization, and abandonment. In Greater LA, this slow emergency has long been treated as a geographical problem, managed through displacement, policing, and coercive forms of care. So the question becomes, where and how does care happen within this slow emergency? Joan Tronto defines care as the work through which people maintain, continue, and repair the world so that they can live as well as possible. For Tronto, care is at once material and emotional, intimate and distant, pleasurable and obligatory. Care is therefore not always innocent, and it is crucial to understand how care is shaped by scarcity, power, and conflict. As Tronto also reminds us, care falls disproportionately on those excluded from politics. Further embracing the complexities of care and the complexities of theorizing care, feminist science and technology scholars further describe care as a situated, embodied practice, or an ongoing tinkering under uncertainty and constraint. For thinking about opioid geographies, I would suggest that critical care theory helps us see three things. First, people who use drugs are not only recipients of care, but caregivers in their communities, sometimes by choice and sometimes by necessity. Second, care for the drug-using body is both spatial and temporal. And third, the politics of care is racialized, gendered, and classed, determining whose suffering is met with empathy, neglect, or criminalization. Building from this, I'm going to briefly highlight three care practices from my own fieldwork in Greater LA over the last several years: mobile care, bureaucratic care, and political care. These examples draw primarily on my volunteer work with one organization, though I did spend time with about 7 different organizations across Greater LA. This organization I will refer to as Third Horizon Harm Reduction, a pseudonym. Now, the first is mobile care. Sandwiched in the middle of a city block, Third Horizon Harm Reduction operates out of a one-story 1960s building. The facade is decked in Flintstone-style rocks, mirrored glass covers the office doors, and a neon sign in one window quietly flashes good vibes. On exchange days, staff load cars with supplies: syringes, snort kits, pipes, foil, fentanyl and xylazine test strips, condoms, COVID tests, pet food, naloxone, and increasingly wound care kits. Mobile care structures much of the week at Third Horizon. Staff drive to several stops, distribute supplies, pack down, and move on. But these routes are not simply logistical. As Gabriella, a community health worker at Third Horizon, describes, on Thursdays we hit our regular spots. We get there and say harm reduction, and they already know us. It's really a friendship. Following Sophie Bowlby's work on care and time, I describe these movements as choreographies. These are coordinated actions of people, materials, timing, and place that make low barrier and peer-led forms of care happen. Within these choreographies, people who use drugs are central to how care moves. Participants redirect workers to new camps or overlooked areas, tell us about who's been displaced by sweeps, provide early warnings about changing drug patterns, often ahead of many formal systems, and pick up supplies for friends, neighbors, and partners. Mobile exchanges also become places where bodies present injuries, not only overdose, but wounds, pain, illness, and infections that often exceed what formal systems are providing for. In this sense, mobile harm reduction creates these temporary zones of care, where support cuts across and often disregards formal service boundaries. The second practice is bureaucratic care. By this, I mean the ways care is experienced and navigated through housing programs, behavioral health services, case management, and county-wide overdose surveillance systems. Much of Third Horizon's work involved what one worker called the 20 small things of care, helping people get IDs, fill out forms, call caseworkers, and manage the paperwork and procedures required to access services and housing. Getting indoors could require people to become housing ready by recounting trauma and documenting disability. Once housed, they often had to remain housing worthy by keeping appointments, responding to caseworkers, and adhering to what one participant described as the invisible rules of mainstream society. Housing then was another threshold of bureaucratic care, offering stability while introducing new forms of discipline and emotional labor. A similar dynamic appears in newer forms of overdose surveillance, which I also group under bureaucratic care. At the county overdose fatality review boards that I would observe, public health, emergency services, probation, law enforcement, behavioral health, and community organizations reconstructed overdose deaths through coroner reports, timeline, and case narratives. Here, care operated retrospectively through data, attempting to repair systems only after death had already occurred. Together, these examples show how bureaucratic care works across scales, from the apartment, courthouse, hospital, and caseworker's office to county-level hotspots and review boards. It can open pathways to housing and services, but bureaucratic care can also turn it into compliance, making people administratively legible without necessarily making them safe. The third practice that emerged in my fieldwork was political care. Harm reduction groups in Greater LA respond to the overdose crisis not only by sustaining life, but by insisting that drug-related deaths are publicly grievable and politically meaningful. In the aftermath of opioid litigation and the circulation of settlement funds, this also means contesting how overdose is narrated and mourned, and whether resources reach those who need it most. Now, this political care took the form of vigils, maps, archives, die-ins, public actions, protest funerals, memorials, practices that refuse the normalization of preventable death in the slow emergency. Third Horizon, for example, often participated in Dias de los Muertos celebrations and hosted public memorials. As a primarily Chicana-led organization, its memorials practices drew on altar-making traditions to honor the dead while creating spaces for overdose education and collective mourning. Elsewhere across LA, community groups gathered outside government buildings, created community overdose maps and archives, and used direct actions to link bereavement to broader demands for housing, healthcare, decriminalization, and harm reduction funding. As interventions into urban space, these practices highlight how the bodies of unhoused people and people who use drugs are already made public, forced to sleep, rest, use, withdraw, recover, grieve, and die in the open. So what can a critical care lens add to multidisciplinary understandings of opioid geographies? For me, it offers 3 shifts. First, it moves us from mapping risk environments alone to asking where and how enabling environments, and I borrow here from Rhodes, are being made. often by people who use drugs themselves and specific to the places that they inhabit. Second, it moves us from intervention as service delivery to intervention as a situated practice and form of collective care, showing how harm reduction depends on local and embodied knowledge, peer relationships, and the everyday struggles through which care can become possible. And finally, perhaps it moves us from mapping outbreak to thinking about movement building. Who is expected to respond when formal systems fail? And how might those networks be supported, perhaps by the researchers themselves, rather than exhausted? So, just to close, a critical care lens, therefore, does not mean simply adding care as another variable to our maps or models. Rather, it asks what our maps, models, and interventions might look like if they take seriously the lived geographies of people most affected by the toxic drug supply crisis. And that does not mean over romanticizing this care work. Instead, it invites health scholars to imagine new solidarities and perhaps new ways of living with drugs carefully. Thank you.
Thank you. This is
Thank
exciting.
you. Thank you, everyone. Those were some amazing and very different perspectives. And we welcome questions, which I don't see any in the chat right now. So I'm going to just pose one or two questions to get us started with our discussion. I know we are limited on time, so I'll try to be explicit. So my first question is, I listened to all three of you sort of commented on this in various ways, coming from a rural, sort of perspective and from low barriers. So across your work, how does your work in particular, or themes emerging in research in your area, consider space and place? This could be the social meanings of places and how that might affect access. For instance, Noah, you discuss access in terms of availability as potentially be deemed by physical location. I'd like to pose, like, maybe perhaps the social meaning of those social spaces may affect utilization as it pertains to, like Sylvia was talking about, the low barrier characterization of those locations may affect utilization. And or as Paul was getting at, does minimizing the mistrust that comes with these traditional healthcare spaces also facilitate more utilization? So I guess I wanted to really, in my own work, I see folks from the suburbs travel really far to the locations in the city, perhaps because that's where the physical availability is for services, but also it might remove them from their own small communities that may stigmatize their behaviors a little bit more. So basically, just wanted to get your perspectives on space versus place and how you see that affecting our work. Did I ramble on too much?
Yeah, no, it's a really important kind of distinction, and I think with the work with methadone, it comes up so much, just because it's such um, it's a place or space that people spend a lot of time at if they're receiving methadone treatment every day, a lot or most of the time, and so it really becomes very defining to your life, whether that means in a good way because you've formed some kind of community, and it's a routine that you've gotten used to, which we hear a lot from people who benefit from some of the spaces. And on the flip side, also, a space that can be very stigmatizing and inconvenient, and a burden, or have a lot of resistance from the community. So um, I think these are really important concepts and kind of questions to keep in mind. I don't know if I have any kind of other things to add. Just that I agree, it's a really kind of important thing to be thinking about.
All right. And okay.
Yeah,
Um,
I'll just hop in there. I
sure.
guess critical geographer, how we think about space is really as something that's kind of produced by economic and political systems. So I think that's very integral to how we think about the, capitalism influencing our discussions around space. And then place is something that can be so much more subjective and affective as well, in the big a word of affective. And a sense of place, I think, is really interesting when I talk to people around. They're kind of drivers for drug use, but they're drivers for access to care as well. And their attachments to certain place, both in memory and both current places as well. So there's a little bit more of kind of the emotional aspect that I think is really integral to understanding how place connects to choices around drug use, but choices also around care and service provision.
Agree with all of that, and I think the thing I would add too, though, is I think in terms of an experiential sense, people's sense of place is also going to be closely tied to their sense of agency, and many people experience their sense of their ability to like citizenship, their ability to participate in the forces that shape their community. It's very closely tied to a person's sense of place. What's the community I identify with? And that often is closely tied to their sense of agency and their ability, if they think X should change, their experience of the ability to change it is often tied to the community they feel linked with, and that's closely tied to place.
Great. So I think we have very little bit time, so I'm going to end something sort of broad for us to stimulate more of a discussion about geography in general. I guess, do you see, or how do you see the role of or inclusion of geography or geographic thinking explicitly, not just as spatial analytical modeling tools? How do you see it playing a bigger role in public health, health services research, and epidemiology in general? Or maybe how it helps maybe facilitate more collaborations, given that we're all from different disciplines. Everyone here, it seems like, reading the biographies, are from different disciplines. The GCCP is an example of how we all collaborate, and just how do we include more of that across disciplines? How do we, provide for more meaningful exchange and opportunities across disciplines when we're working on opioid epidemic, when we're all in our little camps and we need to sort of come together a little bit more and do a little bit more of this. But do you have any ideas about how to facilitate or promote that in our work? It's tough, I know.
And I think this is a really good example of trying to bring different perspectives on a related or the same topic. And I mean, I was even thinking, through Paul and Sylvia's presentations, how, as epidemiologists, we're so used to kind of showing the
Right.
data. What's the distance? What's the average? Like, that's what, like, we'll get that kind of audience involved. But there's so many different audiences that have to understand these issues, and how much can, like, a quote from a qualitative study, or really thinking about kind of broader ethics and kind of history around some of these issues to bring people in and really understand the importance and the context. So yeah, I think we need to do more of this, maybe not just speak to people in our own fields, and try and like really kind of come together in terms of like also what our goals are, who are we trying to reach with this information, or what policies are we trying to influence, and kind of who's sitting at the other side of the table that we can speak to in these different languages or with these different forms of data knowledge or kind of perspectives.
Mm-hmm. And along those same lines, facilitate new research and advancing new research questions. I can think of a million things that came through my mind as an epidemiologist too, right? And I think my mind has been more opened up by qualitative research, and even this first question I asked about hermeneutic meaning of spaces, right? And how I have always been sort of thinking about locations and physical spaces, and locations, just being kind of a dot. But yeah, just understanding all of the meanings that come with that from a qualitative perspective. So we, any other thoughts? I mean, we're at 3:59. I'm a stickler for time. I know folks want to get moving on, but Miranda, do you want to
Yeah,
ask it?
Erebaz, I think it's okay to ask the final. So Sal had a few questions or kind of a suite of questions. And so I
Okay,
think it's fine if we start. I know that some folks might have to drop off, but you can always
sure.
watch the replay. We'll start our roundtable at 4:05.
Mhm.
So just to kind of give 5 more minutes, because
Okay,
yeah.
sure.
Mhm.
I think I kind of blended two of the questions just to because we had some time. But I guess one theme that emerged from each of you, sort of.
Oh, Baz, I meant the question by Sal to make sure we're getting
Oh,
that
I
one.
see. I don't think it was a question. I think it was a comment.
There's a question
There was
now
a
too,
question now.
or
Oh, yes.
I can read it out if that's
Yeah,
easy.
no, now I see. Go ahead. Yeah, I see it.
For sure.
There's a question from Sal, not sure what his last name is, Valadez.
Mhm.
The present state of our public health and healthcare systems in the materialized future of past social constructs and policy decisions. Our vulnerable ethnic, immigrant, and LOTE, LOTE communities are not represented in local public health opioid overdose and mortality data framed on race, Black, white, and other. How do you respond to the question, our children, our dying, can you help us?
I I guess a powerful statement and appreciate that comment. And and I would say one thing too, and that very much resonates with what I was trying to communicate in terms of participation. Because I would say you're right. There's kind of a first order question of is my community, my place represented in the data? But
Right.
I think there's even there's I think what I think myself, others, I think are pushing in the field is there's representation in the data, and then there's also having a seat at the table when the data is made, when the data is interpreted, when the data then is when the rubber meets the road in terms of how it affects policy, how it affects clinical decision making, et cetera. And so I agree with that, but I think the horizon pushing part of this too is it's yes, we need to make sure data is representative and we do a better job of that. But then there's these higher order questions when you start pointing at different institutions, the CDC, and like how well do they integrate a key community of focus into the decision making of their institution and how that data is used, interpreted, and collected. And I think though that's the key reaction I have.
Marina, did you want to add those couple pieces? I missed that.
Yeah, well, I think that kind of so the like how can geospatial data help to close the gap too, potentially as an extension. And Sylvie, it looked like you were thinking of something too. So I wanted feel
Yeah.
free to.
Yeah, I think just having spent some time observing one example of overdose mortality review boards, which were funded by the CDC and was quite novel at the time that there was this funding that rolled out for this. And that was a big question that I put towards this one particular county was even around stuff like gender, around, certain different categories of vulnerable categories, that was not being kind of focused. There's been a little bit of a shift at the local level for people now to try to attempt to focus on certain communities like that. But again, it's not really being published and shared quite widely, this data. And then just on that note, I think what Paul said around it's not just a seat at the table, it's ownership, I think, really given quite directly. And that goes to funders to make it easier for people with lived experience, harm reduction groups to be applying and receiving funding, to themselves also be publishing the data that they are collecting through the nature of their day-to-day work. It is there, and it is particularly within Greater LA, intersecting with a lot of movements around immigration and migrant rights, just to particularly focus on that group. Yeah.
And that seems kind of maybe a charge for the GCCP to think about kind of going forward in the next few years is like what are better resources that could be shared with communities for that local advocacy and that sort of thing.
Absolutely. Well, thank you everyone for sticking around. And this has been a wonderful discussion. And I hope we can continue talking to each other and collaborating and reach out to each other and ideas pop up from this and we could facilitate any forging of new collaborations. Happy to facilitate. Thank you.
Thank you, everybody.
Our roundtable starts in 30
Now,
seconds, right
yeah,
now.
let's kick that off. So thank you guys as we kind of jump right back in. Um, and this too, like the roundtable is really meant to kind of flip the switch a little bit too. So we didn't have a lot of requests for roundtable topics today. So we'll have an awesome student share some of the work in progress from some of our teams. But this, like kind of the topics that we were talking about at the end, that could also be a future roundtable topic of like what are the types of resources that people might need. That being said, feel free to, there's also a Slack channel, which is kind of like a forum for those old school folks, but in a different kind of setting. So feel free to join the Slack that we have, go.illinois.edu/GCCP-Slack. So either Rachel or Mark will share that in the chat, but feel free to kind of continue some of the discussion there. And so let's kick off our roundtable. So what is a roundtable? Broadly speaking, we're looking at a roundtable as a collaborative discussion space, an opportunity to share work, questions, resources, trying to bridge some of the conceptual frameworks with applied work. So sometimes you might have someone with a conceptual project sharing, preliminary findings to see, hey, does this make sense with folks who are actually in the field? Right. Or vice versa. There might be folks from communities who are specifically looking for something to be investigated a little bit further that might be pitched in one of these roundtable discussions. And you'd have a lot of different folks within our community as we continue to grow it to kind of take that charge. So that's what the goal is. And so the Connect framework, we're using that to not just guide the roundtable, but kind of the bigger geospatial consortium in general. There's 5 different dimensions. We're trying to integrate context, and that's really where that geospatial aspect shines. So like, what are the conditions that shape places, but as well as the choices available to people? We're trying to foster a norm of inclusion by kind of by default, like trying to link in different perspectives, experiences, and ideas, and seeing that as a pro, a feature, not a bug. We're also trying to ensure meaningful diffusion of innovation. So this is something we're going to continue to work on and try to get better at. How can we share the work that different folks are doing back out to the community in ways that are meaningful? We're also harnessing technology. So geographic data, geospatial data, there's a lot of different extra dimensions of that might require different types of data wrangling needs. So on the one hand, we have a lot of specialized training that we've already done and will continue to do to kind of make free and open GIS data and tools available to folks who need it to kind of refine and build their work more. But then we'll also be sharing tools and technologies that have been built by members in the community here so that that can be communicated further. And so so look at that. We're almost back on schedule now. So our first, again, very brave roundtable member is Masha Bin Kabir Adrita, but referred to within our lab at Healthy Regions and Policies as Adrita. And she'll be sharing a little bit about extending the risk environment or extending risk environment resources beyond brick and mortar services, a realist review. So some of this will be tacking a lot of different topics you heard across the different panels, but again, we'll see. I think that so she'll be kind of briefly presenting some of the work and preliminary findings so far, and then shift it to questions for folks here. And with that, take it away, Jita.
Hello everyone. Can you see my screen?
Not yet.
Mm,
Oh, it looks
okay.
like it's just me. Okay,
Oh,
there you go. Okay.
okay. My screen. Okay, let me try and share again. Can you see my screen now?
Mhm. And I don't see, it's just that, yeah, there you go. Perfect. Okay.
Okay. So, we've been doing like a realist literature review on extending the risk environment resources beyond brick and mortar services. So we wanted to talk about why this type of literature review was important because there are limitations of traditional access measures. Access to opioid use disorder treatment is often measured using static facility-based indicators, such as number of clinics, distance to providers, etc. These measures assume services are fixed and equally accessible, and they often fail to capture real-world barriers such as stigma, transportation, restrictive policies, and service availability. So there's need to understand how access works, and access is shaped by social structural and service delivery context. In response to limitations in facility-based care, decentralized service models have emerged to expand access to OUD treatment and harm reduction services. These include telehealth, mobile clinics, pharmacy-based dispensing, community outreach, home-based care, low-threshold treatment programs that reduce administrative barriers, etc. So moving on to explaining what the risk environment framework is, this helps explain the structural variable barriers to OUD treatment access. So examples of barriers include geographic barriers, healthcare system barriers, social barriers, policy barriers, and this risk environment framework highlights the need for structural and policy level interventions. So, to determine the scope of the study, we conducted an initial literature review to identify several key constructs, such as healthcare provider capacity, geographic access, the effect of socioeconomic vulnerability. In addressing healthcare accessibility for OUD in vulnerable communities, several theoretical frameworks provide a structural understanding of the complex interactions between the risk environments, built environments, and social determinants of health. And so from our initial overview, we narrowed down the focus areas and theoretical orientation of the review that I'm going to present. So this realist review was conducted to examine how access to opioid use disorder treatment and harm reduction services is conceptualized and measured beyond static facility-based indicators. This approach was chosen to identify how, why, and under what conditions decentralized and community-based care models expand access, particularly within the risk environment framework. So what is a realist review that I've been talking about? Given the complexity of this topic, traditional systematic reviews that focus primarily on intervention effectiveness may not be able to capture how service models operate across different contexts. So this study employs a methodology, theory-driven approach of evidence synthesis designed to explain how interventions work, for whom and under what conditions. Unlike traditional systemic reviews that primarily assess overall effectiveness, realist reviews focus on identifying the relationships between context, mechanism, and outcomes. We call it a CMO, to explain variation in how interventions function across settings. So access to OUD is shaped by complex environment. Since we're amidst an opioid epidemic, it's not just enough to know if an intervention worked. We need to know how it worked, why it worked, and for whom it worked to inform policy and implement successful service delivery models. So for the eligibility criteria for the literature, we subsequently refined through consultation with subject matter experts with extensive experience in access-based research and healthcare delivery for vulnerable populations. Studies were included if they met the following inclusion criteria on the slide, and we excluded some of the slides that focus some of the literature that focus solely not on non-opioid substances or psychiatric medications, or if the literature was reported only on biomedical or pharmacological outcomes without discussion or service delivery or social context. So moving on to the methods. So we first did an iterative search. Then we exported those search results into our software, which was Ryan AI. It kept things transparent between the reviewers. And then based on the eligibility criteria, we had screening round 1, where we screened the titles and abstracts. And then we did a screening round 2, where we screened the entire text. During this time, we developed initial program theories, and after that screening round 2, we did a data extraction to develop our context mechanism and outcome frameworks, and then we mapped everything according to the CMO structure. So for the data
And really
extraction,
quickly, Atrita, just so you know, we're a little over time. So if you want to just jump to maybe one final slide and the questions you'll be asking.
okay. So based on our literature review that we did, we highlighted 8 CMOs, which talked about place, flexibility, trust, capacity, beliefs, digital space, support, and system. And then the access barriers, such as spatial distance, stigma, bureaucracy, and limited providers, cost, transportation, and digital divide, created mechanisms such as embedded care, flexibility, trust capacity, acceptability, digital readiness, and navigation support, which in turn created care outcomes such as initiation, engagement, utilization, retention, continuity, and exclusions. So the contribution to the risk environment framework was that it confirmed place-based risk and expanded to relational, institutional, and digital environments. So what does the entire CMO table say about access? So the strongest implication is that access is produced through interacting risk environment, not by service presence alone. You may have a service available, such as OTP, in a location, but if the individual's interacting risk environment do not support them reaching that service, it doesn't matter if the service is present. So we have to structure our risk environments so that they can have real access to the service that is being provided. So, so the resulting designing principle is design OUD treatment and harm reduction as a layered system, which reduce distance, simplifies entry, builds trust, supports retention, strengthens provider capacity, and removes structural burdens. So the CMO synthesis reframes OUD access as an environmentally produced, mechanism-driven, and unevenly enabled by structural, digital, and relational conditions. So this entire thing confirms the risk environment framework's core premise that risk is structurally produced and access is shaped by physical distance, social stigma, etc. And then it specifies the mechanism, how environments become access barriers themselves. And so this review identifies mechanism pathways such as administrative burden, trust, provider gatekeeping, MOUD beliefs, and navigation supports. And it expands the risk environment framework analytically, which adds like a digital cumulative burden element, such as telehealth literacy, and fragmented systems create a digital risk environment and show that barriers accumulate across domains. So
And I'll have
basically,
to cut it off there. I'm so sorry.
I
We're a little
had
bit
just a
over.
sentence
Yeah.
remaining, so
Uh-huh.
I was just supposed to conclude. Access is produced by environments, rules, and digital capacity, trust, and supports, not by facility location alone. So thank you, everyone. I'm looking forward to questions.
And so these are preliminary findings, correct? And so
Yeah.
what's the main questions you'll have from the audience today?
I
Or
was
what, yeah,
hoping,
general feedback. I bet Sylvia might have some interesting perspectives from
yeah.
like some of the connecting some of the risk environments versus enabling environments. But is it just like kind of a gut check? Is this matching with expectations and that sort of thing?
Yeah, definitely. So we've been working on this to know where are the gaps in the literature, and specifically Sylvia's presentation really resonated with the literature that I've been going through. So I was really hoping for some feedback to expand on future research, and how we can, you know, you know, uh, what do you call it?
Next steps and all that.
Talk
Yeah.
about how, address these risk environments and support the individual risk environments. Yeah.
So we've got maybe one or two. If anyone has any notes or comments, feel free to share that now.
Yeah, I just to say thank you so much. I thought that was really, really interesting. Particularly of kind of breaking down some of the kind of the digital burden. I thought that that use of terminology was really interesting. In terms of kind of care outcomes, I think we've talked a lot about how we kind of conceptualize care and care outcomes. And I saw on that screen there was engagement, initiation. What were some of the other kind of categories or words that popped up there?
Retention,
Retention.
and care outcomes, and
Yeah.
then service delivery.
Right, right. So I think that is this idea of getting to understanding the enabling environment is perhaps expanding some of this idea of how we define a care outcome. And I think there's kind of key points of contact, initiation, retention, but there might be some more expansive ways of how you think about those, perhaps by doing something like a little bit more kind of ethnographic, embedded, perhaps even some interviewing. I could see a beautiful addition to this expanding in kind of the qualitative space. But I think it's so useful, and you're doing exactly that analytical jump between the risk environment to the enabling environment and leaning towards that. And again, very useful, can be a useful application. And that's where the qualitative aspect comes in because we flesh out those ideas of what is enabling. And that will look very differently, I think, in even some of the contexts that we've talked about today, about particularly where these services are located, embedded, who they're serving, all the cultural and different aspects of that. But yeah, exciting work.
I'll just say I think this is really useful and kind of made me realize there isn't like really existing, at least that I'm aware of, like clear conceptual models to kind of I hope this turns into that. Just thinking of we have a study on mobile methadone, and it would be so helpful to really think about these enabling risk environments in a way that's aligned with some of these ideas that you present. So yeah, I hope that that's some maybe a potential product or something that can contribute to our thinking across multiple research disciplines as well in terms of integrating some of these ideas.
And agree with the previous comments. And I'll just say this is probably obvious, but just the fact that you've explicitly have trust in your models and environments to me obviously resonates and pleased to see that. And I think I think I would leverage that space in your model because I think that's a place that again is not put at the front of things often enough. So really encourage you to explore that aspect.
And Sal, you had a really good comment here too. Feel free to unmute. I think that'll be really helpful.
You
Yeah.
say we can unmute?
Yeah, of course.
I hate to bombard people, but this is my life because it's such a challenge. The systems are leaving a lot of people out. And I know that our policies change depending on who's in charge at the macro level. But I envision a future where a lot of these questions that I'm asking and a lot of other people are asking are going to be resolved. And it becomes we'll begin the process of transformation. Now I know we're not supposed to talk about these things, but that is the underlying cause for all the suffering and the deaths that are going on right now. I mean, uh, how can you address that question that I asked? Our children are dying. Came back in 2017 when it was an environment where Title VI and all the policies were in place to address those issues. And it was difficult back then, so it's almost impossible now. I'm just hoping that at some point we look at things maybe differently. Maybe we need to use quantum social science in this process, in the entanglement of being and looking at groups differently because we have the technology, but our social sciences haven't changed from the Newtonian to the present. And so I'm proposing that there are studies, there are folks that are doing work around quantum social science, and I would suggest that maybe as a group we look at these concepts, the entanglement of being the primary one that I work with. Karen Barad, who's a feminist, and a fantastic does fantastic work. But I want to take a lot of this space, but I'm leaving with hope that we're heading the right direction, but it's my hope is blunted by the reality of people overdosing and dying without being represented in the data. And
Sure.
we know
Well, there's
why.
more work to be done. And I think that part of this too, we can, if you'd be interested, we can definitely um peel some of this for the next roundtable that we have to kind of do
Yeah.
some more brainstorming. And then let me just so that we're able to close in 4 minutes, so that even if we were delayed in some ways, we'll still end up being on time at the end. Um, so I'll actually jump to this really quickly because we're actually going to have a session in July. Our next GCCP topic or meeting will actually be a workshop on accessing spatial data. We'll be using R, but I'll also highlight some other things. But specifically, like our team for the also as part of the grant that this is all coming from, we manage the opioid environment policy scan. If there's request for, like, maybe we're not able to get disaggregated opioid mortality data, but we can get very fine level social demographic data at track levels. And so just that's something that it's no problem to make that a highlight. We are open to requests like that, and there's different ways to kind of get at those answers or get at those questions that you're having. So that's going to be coming up in July. There's a lot of agent-based modelers in the house today, which was super exciting. Well, we're going to have a panel on specifically agent-based modeling next year. There's a whole other Bayesian camp. So Bayesian spatial statisticians, don't worry, we're going to have one from you. There's also interest in having another panel in the future on policy environments to see if that, that might be different from our talk today or not. But so these are coming up, but we're also taking requests. So if there's specific topics that you guys want, let us know. And going back here, so make sure that you've officially joined so you get our newsletter because we'll, like, for example, the Data Disaggregation Advocacy Network, we'll definitely add that in the newsletter. And if there's specific resources, opportunities, or announcements that you haven't been able to share so far, I'll tag Mark here, let Mark know, and we'll make sure that that also gets into a future newsletter. We've got our Slack channel, we've got our LinkedIn group, and then here you'll be able to see the specific. We have a YouTube kind of playlist of previous topics that we've done in this space, and so we'll be adding that down there. So there's that. And then me doing that was kind of a pain because it's going to take a second to reload. But the final topic will be let me see here. Also, if anyone will be in Phoenix at this the EPI conference in June, we'll be doing an Introduction to Spatial Epi and R workshop there with Ashlyn Weimar, who we unfortunately lost her to Harvard. So, not holding a grudge there, but she'll be out there. So, and Ashlyn has done a lot of work as well on the opioid environment policy scan. So those are all things to look forward to. And even with all the different challenges, we're grateful that we have funds to do this. So we have found ways to kind of work collaboratively as a team. So we're grateful for all of